So if it's higher up on the attached gingiva, I'm thinking more about a root fracture. If it's lower down in the buccal sulcus, then it's more likely to be coming from the apex, and that is, I'm not saying it's probably less likely to be a fracture. Whereas if it's really high up, you're thinking maybe a fracture somewhere in the root essentially. If we come back to what I said about why these more straightforward cases, why they fail a lot of the time, as I said, it's because the GP is already not that well condensed to begin with. So in terms of removing the GP, my first go-to in those kind of cases would always kind of be headstrong files. So the reason I say that is because they're hand files, so they're probably a lot safer than using sort of rotary files. You can control it a bit better as well.
I used to think that root canal retreatments were only for specialists and that GDPs should not touch them. Well, how wrong was I? When I entered my training post in Sheffield, it was a dental core trainee post. Now, for the rest of the world, it's kind of like a residency. It was like 1 year attachment with the restorative department, and this was in a dental hospital. I remember seeing a case. It was a central incisor, and it already had a root filling. So it was up to me to do the root canal retreatment. Now, I was scared. I was like, oh my God, I've never done a retreatment before. I've never had to remove GP. And also I was learning how to use the scope for the first time. So for me, I was nervous. I was thinking this is very much specialist treatment. Will I be able to carry it out? Now, when the case actually came in front of me and I saw the radiograph, it literally was like a GP cone floating in this big wide canal. Just that one solitary master cone, plenty of air and fluid, if you like, around it. No wonder it failed. And I accessed the tooth. I literally, with my tweezers, could see so clearly that GP cone. I picked it out and I carried out the root canal treatment. And that was the easiest root canal retreatment ever. And it just made me realize that I had this limiting belief that not all retreatments are the same. So I guess the point of this episode and what we'll learn with my guest doctor Ayman Al-Sibassi is how to know which retreatments GDPs should totally get involved with and how to know where perhaps this is one to refer to our specialist colleagues. You'll find out the best ways to remove the gutta percha. Is it gutta percha or is it gutta perca? Honestly, endo is not my thing so much anymore, so I don't even know how to say it anymore. But you know what I mean, the GP, which is the best instrument, which is the best solvent. And interestingly, how much solvent should you actually be using? Like, should you be flooding your canal with solvent or should you be just using tiny drops on your instrument? And related to what I just said earlier, I want you to understand more about risk and predictability of retreatments. What are the red flags that you should not pass go? We cover all this and so much more in this episode. Now, if you're new to the podcast, welcome. My name is Jaz Gulati and therefore you are called affectionately the Protrusive. We are the community of the nicest and geekiest dentists in the world. So if you want to join that community, head over to www.protrusive.app. The idea is that we don't want anyone to feel isolated, that they can't ask for advice. If anyone's feeling nervous or unsure about certain treatments, well, check the whole backlog of all the episodes we've done, but also having peers, like-minded Protrusive to support you is exactly what we've created on our app. Now, those of you who are returning viewers and listeners, please do hit that subscribe button. And as you know, every PDP episode, I give you a Protrusive Dental Pearl. Now, by the time episodes come out to publish, it's actually probably been a few months sometimes. What I'm kind of doing now is like early spring now, and I'm kind of getting ahead so that I can enjoy my summer with my family, but you guys all get an episode once a week. That is the dream. And one thing that you guys ask me all the time is, Jaz, how do you do it? How do you stay motivated with your podcast? How do you get it done? How do you balance family, children, clinical dentistry, and of course, watching cricket, which I love doing? How do I make it all happen? Well, I'll tell you something, guys. Just from the heart, I have a big team now and they help me so much. It's a real team effort to get every episode out. Every episode that has CPD or CE especially has probably been through about 4 different people and about 3 of those are dentists before it actually reaches publication. That's so that we can actually quality control the CPD questions, the learning outcomes, and produce the best done for you notes ever. Like, our premium notes are just such a brilliant summary. The key takeaways are summarized so nicely in our PDFs. And to actually make that happen takes a lot of effort. Now, because I have a team on board that rely on an income from Protrusive, it is so motivating to make sure I don't let my team down. So I guess what I'm trying to say is thank you so much, guys. Thank you so much for supporting the podcast. I'm feeling in a very grateful mood today because yesterday I was at Dr. Pascal Manier's lecture live in London, and I met so many of you that came up to me and said thank you. Like, literally, I was just amazed. Like, I was almost getting very emotional. You guys were coming and saying, hey, Jaz, I just really want to say this. I want to get this out of my chest. And you said to me, Jaz, I just want to say thank you. Thank you for all you do. And honestly, I'm passing this straight to my team. I really appreciate your kindness and all these years you've been listening and our channel's been growing. Thanks to you and for you recommending your colleagues. So if you still know people who haven't heard of Protrusive, please do send them episodes like this. The Protrusive Dental Pearl today is taken from Dr. Pascal Magnier's lecture yesterday. It's very fresh in my head. Sometimes I get anxious about, oh, which pearl will I share today? Like the first few episodes, it was easy. I had loads of pearls I could pull out. 300 episodes in now, it's difficult to actually think of a protrusive pearl to give you. So it's a really cool one yesterday from Pascal Magnier. He says that when we see a crack in enamel, how do you feel? What do you think? Do you think that this tooth needs to be extracted? Hell no, okay? Cracks in enamel are not a big deal compared to cracks in dentine. Cracks in dentine are serious stuff. Cracks in enamel are common. A crack is how the stress has dissipated. So the real pearl here actually is when you see a crack in your ceramic, don't think that it's failed. Don't think that you're a failure. Don't think that ceramic needs to be changed just because of a crack. And that was really eye-opening because sometimes when you place a ceramic and you see it a few years later and you start to see a crack inside, you think, oh goodness, this has failed. But actually we shouldn't think that. If we accept it in enamel, why can't we accept it in ceramic? Providing that's been bonded properly. A bonded ceramic is a completely different beast to a cemented ceramic. So in bonded ceramics, a crack is not the be all and end all, and please don't interpret that as a failure, is our tip for today. So turban tip to Dr. Pascal Magnier for sharing that in his lecture yesterday. Anyway, let's dive deep into root canal retreatments for GDPs, and I'll catch you in the outro. Ayman Al-Sibassi, welcome to the Protrusive Dental Podcast. Can't wait to geek out endo stuff with you. But tell us the story, right? You just literally told me that you have a baby, congrats, at 10 months old, but he or she, sorry?
It's a he. It's a boy.
Okay. Boy, name?
His name's Suleiman.
Okay, so Suleiman was born a day before your specialist exam. Is that right? For endo?
Yeah. Basically, yeah.
What was going through your mind and how did you cope? Did it affect your exam in any way?
Yeah, well, I think it was probably, I made it up to be more than it was, only because, the day before the exam, you're kind of you're not getting any more information in at that point anyway. You're kind of just bugging out at that point. You're kind of stuffed with information. So in reality, I couldn't take any more information in. It was more just the panic of how am I going to do this? Is my wife going to be okay? I was thinking a little bit more about my wife, my son, not about revising more, but just are they okay? That kind of thing, basically. It's just, I had good support, to be honest. I had a lot of good support, my parents, my mother-in-law, and my supervisors were super helpful as well. One of my supervisors even came and dropped a bag of stuff at the hospital to help out and stuff.
Wow, that is a real special story. Where did you do your specialist training?
University of Liverpool.
That is really cool, man. I love that your supervisor was supportive like that. That is, we need more of that in dentistry.
Dr. Myward, yeah.
Okay. Well, I'm glad you name dropped. Buddy, look, I'd love to know a little bit more about you. Firstly, my listeners are going to love, those listening on Spotify, Treadmill, you have this loveliest, deepest voice, which is just, the podcast listeners are going to absolutely love this, by the way. So that's a great plus. They're going to get through the end of this one, which is great. Tell me about yourself, mate. How did you get into endo and the usual stuff?
So essentially, fourth year of uni, when we kind of started doing undergrad, this is undergrad sort of endo, we started around third, fourth year. And I did a couple of endos and I just thought, yeah, that's me. That's what I'm going to do. So I kind of knew since towards the last couple of years of undergrad that that's what I wanted to do. And I always kept telling my colleagues, this is what I'm going to do. So kind of when I left, I focused on that a little bit during my FD year. Did a little bit of it. Well, I didn't really do any of it because I went into DCT a year after that. Did a year in MaxFax and then came out 2 years in general practice and then straight into specialist training. So I probably in total did about 3 years in general practice, 1 year of MaxFax, and then went into specialist training. 3 years full time basically up in Liverpool. But I just liked it. I felt like it was a bit of a dark art. I liked all the gadgets. I like the instant results that you see as well. And I thought it was just quite niche. Not many people like it, and that kind of drew me into it as well.
We need more endodontists on the register. There's not many. I mean, last I checked years ago, maybe 9 years ago, if you know this number, it was something like 264 9 years ago. I remember that number of specialist endodontists registered in the UK.
Funnily enough, part of my sort of doctoral thesis at Liverpool, which is part of the research we have to do there, attached to our specialist training, I had to actually look into how many there are. So there's still around 300. But the thing is, a lot of them will be restorative consultants who don't necessarily do endo monospecs. There's probably a lot less than that.
Yeah, okay. No, that's a good point. And just about your training, I think it'll be very useful for our colleagues who are in earlier stages of their career, decision making. You knew you wanted to do endo, right? And you did almost like a distraction year. If you think about it, it was a distraction year when you did MaxFax, because it kind of, one might think it took you away from your goal, but maybe you needed it to actually reach the endo. Hand on heart, when you look back at it, do you think, oh man, I regret doing that year? I wish I did private practice, or I wish I did more endo. Or do you think back saying, you know what, you're so glad because it made you a more rounded clinician? What's your take on that?
I don't regret doing it. No, definitely not. Number one, because I felt like the year itself was quite full on. So I felt like it made me a little bit more resilient in terms of like doing things, just working hard basically. So that was one. And then the second thing is we did a fair bit of oral surgery on that rotation. So it kind of gave me some more surgical skills, which nowadays in endo are becoming a lot more important, because endodontists nowadays, historically, it might have been maybe a little bit more about the endo with like apicectomies and stuff like that being done by oral surgery, but it's becoming a lot more within the remit of endo to do things like, apicectomies, auto-transplantations, intentional replantations, root resections, and then even like resorption repairs, perforation repairs, stuff like that is all kind of coming within the remit of endo now. So I think for that, it's quite useful.
Yeah, that's good. It's part of your stepping stone. I can see those surgical skills being useful later on. Well, thanks for talking about your journey, Ayman. I really want to get into the topic of today, which is retreatments, root canal retreatments. I remember when I was working under my consultant as a DCT, when I used to type it, when I used to like write in the notes Re-RCT, he was like, no, you must write root canal retreatment, because what is a Re-RCT? Like, it was one of those pedantic things. But anyway, I remember, and I mentioned my DCT because I remember I had this limiting belief, Ayman. Yeah, I had this limiting belief because I was a GDP, I was a DCT, if anything, right? And I was like, I can't do a Re-RCT, I can't do retreatment because I'm not a specialist, therefore I cannot do retreatment, was my limiting belief that I had, right? And so I remember doing this one case, it was a retreatment, right? And it was like single center incisor, and it was like, the thinnest, skinniest GP point, right, in this widest canal, like probably every time the patient walks, the GP point is probably moving side to side in the tooth. You can just imagine it, right? And so when I accessed that and I literally got my tweezers and I pulled out the GP, right, and I treated it and the sinus tract went away, I was like, holy moly, I just did a root canal retreatment. And then you realize, okay, hang on a minute, that was just a limiting belief that actually they're not all the same. So my first question to you on that remit is, what do you think about the scope of Re-RCT for GDPs versus should it be referred to specialists?
Well, I definitely think they're on a spectrum. So some of them, as you said, like will be a lot more straightforward, like the one you described, versus some others which can get complex depending on what they are. So you'd always have to kind of do a complexity assessment. So there's different tools available. The one I've used and the one I'm most familiar with is one called ECAT. It was developed by a couple of colleagues at Liverpool. It's essentially an online tool that you can click through, and it just basically gives you all the factors which will give you how complex it is. So things that I would look at just in terms of what would make it a very simple case, I'm usually thinking about patients medically fit and well, no sort of complex medical conditions, things like sort of bisphosphonates, not very anxious, mouth opening's quite good. So that would be the sort of patient factors I'll be looking for. And then tooth-related factors to make it simple. Usually you're looking at like an anterior tooth, usually a 1 to 3. Premolars can get a little bit tricky sometimes, not always, but the anatomy, I find that in my clinical practice, I always get kind of fooled sometimes by how complex premolars can be. But yeah, so 1 to 3 is usually, as you said, GP points kind of floating around. Yeah, those would be kind of simple cases in my mind.
Mm-hmm. And then what about when you see one and you see that it's been like there's no voids and it looks like it was a decent job, and I look at it and I'm like, I know the radiograph. The problem is the radiograph doesn't tell you if rubber dam was used. The radiograph doesn't tell you if hypochlorite was used, right? So so much information you miss when you look at a radiograph. But sometimes you see and it looks fairly good quality in a radiograph. At that point, I'm very happy to refer because I'm like, okay, well, there's something else going on here in addition. And I just think, our specialist friends need to eat as well. So this is the kind of stuff they should be eating. I'm just going to do the cherry picking as a GDP should do. But of course, some GDPs, they love endo and they kind of like have a special interest. They do extra courses. And then they if it genuinely gives you excitement and a challenge, then do it. But for most GDPs, it's like, okay, that's a point where I see a well-filled canal, there's no voids, it might be a little bit more challenging to remove the GP, which we'll get into. Is that a fair way to think about it for a GDP?
Sorry, can you repeat that last question again? I did just cut up there for a sec.
Is that a fair way to assess a tooth as well when you look at how well it's filled on the radiograph?
Yeah, so that would be one of the things that I would say would make it more complex. It's out of one of many factors. So if it's already like there's certain quality standards that we look at for endo. So the main things would be, is it filled to within 2 millimeters of the radiographic apex? And is the root filling well condensed? And then also like coronally you're looking too. So is there any obvious coronal leakage there or anything like that? So if there's nothing obvious you can identify on the x-ray that could be the reason why it's failed, and you can't see, for example, any cracks clinically that you're picking up as well, then yeah, I mean, those cases tend to be a little bit more complex. There might be like missed anatomy inside that you can't see. Again, you don't know what happened previously. And there could be a lot of leakage. So a lot of the times, if the root canals are old, there's studies that show that a lot of the restorations, or almost all of them, have some coronal leakage to a certain degree around them as well. And that can cause sometimes failure. I mean, in those kind of cases, I would always kind of be thinking about CBCT, because there's no obvious cause of what is causing it to fail that you can see. So that would usually give you some more information. Yeah, I mean, that's what I'm thinking.
That's fine. So, Ayman, how common is CBCT becoming in your practice as an endodontist now, either at the consultation appointment, or are you really happy when a GDP sends a referral with a CBCT and gives you just more information? Is that becoming more common in practice now?
Yeah, it's definitely becoming a lot more common in practice. And especially as with CBCT, the machines are going in the direction of the doses becoming, or the radiation dose is becoming reduced over time. So as that happens, I think it will become a lot more used. To be honest, the doses at the moment, they are not, I mean, when you look at them in relation to like what you do in MaxVax, for example, I remember we used to take full face CBCTs of everything, for example, when the patient came in. So dose is actually like way lower than that. So yeah, and those doses are only going to come down with time. So as that happens, it will become more common. In terms of when a GDP... Can you give me some examples of like you saw the CBCT and it completely changed your treatment plan, or it completely changed your perception? How often does that happen? Well, I can think of a case that happened actually a couple of weeks ago. So it was lower molar. It was a Re-RCT case. A patient came in and the root canal filling just looked like it was voidy, big PA lesion, voidy root filling. So anyway, I started the root canal filling, root canal treatment, just based off of the PA. I didn't really suspect anything, but and I opened the tooth up. I was getting quite early apex locator readings, much earlier than I expected. So then I took a CBCT of the tooth, and I found that actually the mesial roots, that sort of danger zone, that distal concave aspect of the mesial root, was kind of completely resorbed away. So the GPs were half sticking out into the defecation area, which wasn't obvious on the PA. So that means that the tooth is unrestorable.
This was a resorption and not like a strip perforation. How can you tell?
Well, yes, it was difficult to know. And my suspicion is it probably was resorption, because there was a massive lesion associated with it into that furcation area. So sometimes you can get something called external inflammatory resorption, which kind of eats away at that area of the tooth as well. But it may well have been a strip perforation. I'm not entirely sure, just looking at that. Yeah, I mean, that made, in my mind, the tooth unrestorable. There wasn't really much that I could do about it. So I had to tell the patient, I can't really do anything with it. Whereas previously I was about to go and, re-root canal treat it.
I'm going to get into removing GP and that kind of stuff. But now that you've mentioned this point of a very niche scenario, one of the questions we had from the community, I asked last night, I said to everyone, hey, I'm recording tomorrow about re-RCTs. And so one question was, it's a tricky question, Ayman, right? Not in terms of like tricky endodontically, it's tricky more in terms of ethical dilemma and charging of patients. Let's talk about this before we go into the details of re-RCT further. You have this scenario, just like you described, right? Invested time in treatment. You're now time committed. You do the CBCT and now the tooth is unrestorable, okay? Does the patient then leave and they haven't paid any money to you, right? Because now they've just been told that they can't do it. Is there a fee that was agreed in terms of the consent and the consultation that you do? Is that, okay, if it can't be saved, you're going to be charged this much and you'll have that information? Because imagine as a GDP, you trying to, like the example Julia Tully, the example she gave is like she opens up a molar and she can see the three main canals, upper molar, and then she just about sees the MB2, but she gets stuck at that stage. She can't get into and navigate MB2 properly. And now she's like in an ethical dilemma. She feels that, well, okay, to get the best result, I need to refer you to the endodontist, but I've just spent an hour and 15 minutes accessing, removing caries, and that was all part of the endo, and now I have to refer. Is it fair that I'm now charging my patient for my initial fee? So there's no right or wrong answer, but I'd just love to know your take on that.
So two things. So from my perspective, I always would consent the patient that the tooth might be unrestorable. It's almost like for almost every single case, unless it's like, barely restorations, minimal or anything like that. But even then, I'll say, look, there might be a deep crack in there that we find or something like that. So I'll always consent the patient for it being unrestorable, and I'll quote them a fee for an investigation fee if we don't go on to completing the full root canal treatment. So that's, for example, that's how I managed the case that I just mentioned. So I still charged them the investigation fee, charged for the CBCT as well. Obviously, I didn't charge for the full root canal treatment. In terms of if they can't, for example, they can't find the MB2, a lot of the times the patient for the GDPs, the patient a lot of the time will come in pain. So you're still getting the patient out of pain, for example. And I would still, for example, charge maybe half a root canal fee, because you still have done something with the patient. You've got them out of pain, for example. You don't necessarily always need to find MB2 to get the patient out of pain. And I would assume that also it's part of your consent process sometimes to say, sometimes we can't find canals, we might need to refer you. So if you need to do that, I would, again, just consent the patient for potentially taking maybe half the fee or a third of the fee, because it's still your time at the end of the day. You're still helping the patient out.
I agree with you so much. I feel as though what we don't want to do is like feel bullied or coerced that, oh, because I missed one canal or I can't find it. Like you're still doing the right thing. You're thinking, okay, there's still, I think someone else can navigate this still, but you would have got them out of pain. You would have done the hard work of caries removal, access removal. Sometimes you do a pre-endo build-up. You do all that. That stuff is valuable. But I think you just nailed it. As long as you have this standard spiel in these situations, if we can do the root canal and everything goes well, this is the fee. Like you tell your patients your fees before you do the treatment. But it's like, sometimes things are really, really tricky. If they're really, really tricky, I need to refer you. Don't worry, Mrs. Smith. You won't have to pay the full amount. You have to pay a third of X or a half of X. And at least that way, we've done some of the work. And then the endodontist, who may charge this much, will do the rest. And now you've just been like super clear. And if you have that patient who doesn't consent to that, then that's the whole point of the consent conversation, right? Don't think that if I tell the patient this, they won't go ahead. Well, that's actually the point of consent, right? And so you want to have a patient who's on board and who's very reasonable and understanding of that, right?
Yeah, 100%. Yeah, I would say, like, for example, you made a good point as well in terms of the caries removal. So a lot of the time, root canal treated teeth, the majority of them are quite knackered to start with anyway. So you will almost always do like a restorability assessment as part of your root canal treatment. You will be stripping out amalgams, old composite, caries, and that obviously is still valuable. Me as an endodontist, if you refer a patient to me and it's already had the pre-endo build-up, I'm like, thanking God at that point in time, because that actually saves a lot of time. So you've obviously done that service for the patient. It's something that you've done. You've helped the patient out, and you've saved me having to do it as well. So yeah, I would definitely still charge for that.
I think a really good way to do it, because this is obviously a real world issue. And then so there are some colleagues who would do the following. They would charge a fee for the restorability assessment and pre-endo build-up, and that would come as a one fee, okay? And then the second fee would be the root canal. And then at that point, it's like, oh, you know what? I'm not charging for the root canal because I didn't do it, but I did all this stuff. And it makes sometimes sense for the patient's head.
Yeah.
And so that might be a model that some practices may wish to use. The main thing is that the conversation is had beforehand. So totally, I'm glad we're on the same page there. Just going back a bit before we talk about removing GP, any like red flags that GDPs, when they look at root fill teeth and they're thinking, should I do a Re-RCT? Like the one I mentioned was like, if you see that it looks like a reasonably good root filling, that is kind of like a little bit of a red flag, that, should I be doing this? Another one would be like, if you see a separated file in there, then obviously that's one for you guys, not for us, unless you are that way inclined. But I'm just giving like an easy guide to GDPs. If you see, sinus tract for me is just a sign of infection. I know that can reduce the prognosis of your Re-RCT. Would that come as a red flag for you?
Just a sinus tract by itself? No, because as you said, it's just basically an external sign of the infection. A sinus tract by itself doesn't mean too much. Although, what I would say is, depending on the position of the sinus tract, that can sometimes indicate a fracture in the root.
Tell us more. Where are you worried about?
So if it's higher up on the attached gingiva, I'm thinking more about a root fracture. If it's lower down in the buccal sulcus, then it's more likely to be coming from the apex. And that is, I'm not saying it's probably less likely to be a fracture. Whereas if it's really high up, you're thinking maybe a fracture somewhere in the root, essentially. Not always. It's not pathognomic for a fracture, but yeah, I'm just a little bit more suspicious at that point, basically. And I think there is some research, I can't remember the name of the paper, but there is actually some research on the position of the sinus tracts and how related they are to the presence of a crack. So yeah, which also confirms higher up on the buccal attached gingiva, more likely to be a fracture.
That's a good one. And then obviously if there's a post in the tooth, which actually one of the questions was, we'll come to it later, any tips on post removal, but I want to save that for later. If there's a post, right, unless you're really into that kind of stuff as a restorative dentist and you get a kick out of that stuff, then I'd probably say that's the one to refer. I'm sure you don't get a kick out of removing posts.
Is the question, do I get a kick out of removing posts?
Yeah. That's the one where you're cursing your referring dentist and not saying thank God.
Yeah, exactly. Yeah. I mean, they can take some of them to come out in like 2 minutes, and those ones are fine, and you can kind of tell which ones those are going to be because they've got loads of space. But some of them, they can take up to like an hour, like the long ones, well adapted, really fat posts. But in those cases, a lot of the times you'd be thinking about apesectomy in those teeth a lot of the time as well, because you might take the post out at the end of it and see that, the tooth is actually unrestorable because it's already been prepped, to death to actually get the post in there in the first place.
And we'll talk about some tips to remove posts, but any other last few red flags before we move on to GP removal?
There's a few. So kind of, yeah, if anyone is interested to see like this in a bit more detail, again, that ECAT tool goes through every single factor that you could kind of consider. So if you ever have a case,
I will link it. I will link it.
Yeah, I think that would be useful for anyone listening. So yeah, that it basically goes through every single possible factor. So just made a note of a few. And again, like I would always kind of divide it into patient, mouth, tooth-related factors. So patient-related factors, again, so for example, bisphosphonates, because there's always a small risk that when you're doing patency filing, for example, potentially, not always, but not a high risk, but that you could stimulate some kind of Emronge reaction, something like that. That's one. Again, if they're really, really anxious, you don't want to be, sort of faffing about with taking a long time for root canal treatment as well. Limited mouth opening is one as well. That's one we get quite commonly in referral practice too. So tooth-related factors, I would look from the crown down. So number one, if there's really, really deep restorative build-ups required. So if you're looking at like the margins on almost on bone, that's one, because you want to make sure you've got a good coronal seal. So that's one that I'd be looking at. Any crowns or posts that you're looking at there, especially if the crown or the post is in a different angulation to the tooth on the x-ray. Cracks is quite a big one, especially becoming more common nowadays as well. Cracks specifically is also associated with periodontal pockets, because often with isolated periodontal pockets, because often that means that the crack is extending down the root surface.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I wanted to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
Now, those teeth, to restore them effectively, you often need a microscope because you'll be bonding composite down the canal orifice, and to do that without a microscope is quite complex. So if you see an isolated periodontal pocket associated with a crack, a lot of the times that would be quite a complex case to manage. Previous RCTs, as you mentioned, if the RCT looks good on the periapical radiograph, well condensed, within 2 millimeters of the apex, that would be, you're thinking, why has this failed? So that might be something more complex. And also, it's well condensed, the GP is going to be a lot more tricky to actually remove as well. It's not going to be straightforward. Fractured files, you mentioned as well. And then more niche things I'd be thinking about are things like developmental anomalies. So sometimes you get like taurodonts, palato-gingival grooves as well, which can sort of mask as endo problems. C-shaped canals as well. Those are sort of things. Fast breaks as well. That's quite a common one that you see. So it's kind of difficult to explain without an X-ray, but usually you see it, for example, on premolars. This comes back to our premolar, what I was mentioning about premolars. So you see the canal's there, get to the apical third, and then it just disappears. And then often that means that you've got some sort of deep apical split. So that would be quite a big red flag as well, because often you need a microscope to actually see all the way down there and actually help you to navigate around that apical complexity. Resorption cases as well. So depending on what the resorption, especially like cervical resorption, which is probably becoming more common nowadays. So resorption cases, because a lot of the times they will need like surgical repair to actually access and fix. History of trauma on anterior teeth. Sometimes they'll have trauma to multiple teeth, which needs quite complex management. A lot of the times as well on the PA radiographs, you won't see root fractures. They don't necessarily turn up, and that might need a CBCT to actually reveal that. Periostatus as well, so perioendo lesions as well, which is actually the topic of, that's what I spent 3 years sort of researching at the University of Liverpool. So perioendo is quite a big one, because a lot of the times the endo might be straightforward, for example, but to manage it appropriately, you will need a lot of the times regenerative surgery, which will become more complex in those cases as well. So you might see, for example, an anterior tooth, re-root canal treatment might be quite straightforward, but then to actually get the bone to regrow and the mobility to stop and the pockets to come down, you're actually going to need like bone grafting, membrane, stuff like that. So perioendo, especially, like there's a new classification. It's by I think it's the European Society or European Federation of Periodontology.
Perio people, they love a classification. Like they'll bust one out every 6 months. Like they are the kings of classification.
So there's a perioendo lesion one. So they've divided it into grade 1. There's grade 1, 2, or 3, basically. Grade 1 is if there's an isolated pocket associated with the tooth. Grade 2 is one pocket on one surface, but not isolated. So it's a wide base. And then grade 3 is wide or pocketing on more than one surface. So grade 2 and 3, often those cases will require regenerative surgery, bone grafting, or enamel matrix derivative to actually help them along. So those would be quite complex cases to manage too. I mean, I've been through quite a lot. Yeah, sorry.
You have, over the last 2 minutes, you shared so many red flags there. And so the general dentist listening to this, like, wait a minute, like, are there going to be enough cases left for me? So my question then for you is, how many re-RCTs do you do and think, you know what, the GDP could have done this?
A lot, yeah. So the good news is a lot of the cases that I do that are re-RCTs, then these things are the red flags that I mentioned, they are there, but re-RCTs fail for common things. What's that phrase? Common things happen for common reasons. So the most common thing that I see with root canal treatments failing is poor coronal seal and poor apical seal. So the GP's floating about, or there's caries or some kind of leakage coronally. And those are the most common things that I see in terms of why those kind of referrals come through. Probably, or maybe not common, probably about 50% of them are like that. Yeah, I mean, there is a lot of cases like that. So while there are a lot of complex things, there's also a lot of simple things that are easily managed.
I think
easily. That probably sounds
easier.
So easier. Yeah, that's the idea. Easier. Yeah.
I think, Ayman, like people might be thinking that, hey, why is an endodontist telling a dentist that you could do a re-RCT? And I think it's because you have enough, you guys are not going to go hungry if the easier re-RCTs are done in general practice to give you the stuff that you actually trained to do, right? The things that actually are trickier. So let's talk about when you are a general dentist and you're learning about doing retreatment, it's something that, that little bug bit me when I was about, 2 years qualified. And the first thing was actually DF1, I did my first one. And I was like, how do I remove the GP? And so then you look into it and then you think about different oils and stuff. At the time I had bought, because obviously chloroform in practice was difficult to get. So I used eucalyptus oil. I remember using it and then like a drop of it went in the rubber dam and I forgot which dam it was and a huge hole appears in the rubber dam. I'm like, wait, no one told me this would happen, right? This wasn't in the playbook kind of thing. So there's a lot of things that learning. So it takes us nicely to the question, okay? What are the tips that you can give to general dentists to remove GP effectively and safely? and efficiently.
Yeah. So if we come back to what I said about why most these more straightforward cases, why they fail, a lot of the time, as I said, it's because the GP is already not that well condensed to begin with. So in terms of removing the GP, my first go-to in those kind of cases would always kind of be headstrong files. So the reason I say that is because they're hand files, so they're probably a lot safer than using sort of rotary files. You can control it a bit better as well.
Hey guys, it's Jazz with an interjection, just a really quick one, right? H files, K files, and C plus files. Let's just briefly, really quickly go through the differences, like going back to basics. So K files are the workhorse, right? These are the main files we reach for. They are triangular or square in cross-section. They're used in a rotational or a push-pull watch winding kind of way, very versatile. And they cut dentine both on insertion and removal, but not as aggressively as H files, which stands for headstrom files. Now, before we talk about headstrom files, we just have to point out that whilst K files are like a workhorse and they're so versatile, they're not as aggressive as debris removal as H files are. And when you get a calcified or sclerosed canal, then you know what? K files are not as good as the C plus files, which I'll explain in a moment. So H files, I was always taught in dental school that they look like a Christmas tree. And whilst they are circular in cross-section, they do actually look like a Christmas tree to me. Now, they shouldn't be used in the same way as you use a K-file. Absolutely not. These are specifically push-pull. And they don't really do much when you push into a canal, but when you pull, they are very aggressive and very efficient. They're good at removing debris, they're good at cutting dentine, and they're even good, very relevant to this episode, at removing gutta perca, which is why they're used for retreatment cases. So whilst they're efficient, you have to be careful because you could break them if you misuse them. So please do not rotate H files and use them like a K file. If you misuse them, you can cause all sorts of errors within the canal, like transportations and ledges and that kind of stuff. Now, lastly, the C plus file. I don't have much experience myself in using these files, but they have a very active tip. So they're really good for sclerosed canals or calcified canals. That active tip allows you to get really good tactile feedback. And it's just ideal for the negotiation of sclerosed canals. The main thing is to use the file for its intended purpose in its intended way. Don't go using a H file in a curved canal in the wrong kind of manner, because that's asking for a file breakage. Now that's back to the...
So I would probably go for like a size 35 to 45, nothing smaller than a 35, because when you screw it in, I find that they are more likely to fracture. So yeah, I would go for like a size 35 to 45, something in that range. And yeah, you kind of just get your estimated working length off the radiograph. And then you'll kind of go into the top of, say, the most coronal portion of the apical thirds. I'll try and get the file down there. Screw it in just very gently. If it's not going, I wouldn't force it because you can end up ledging and stuff like that. But oftentimes you'll literally feel the headstrom file passing down quite easily into space, or you'll feel it screwing into like stickiness, and that will be the GP. So get it down there, make sure you got your length, and then you just kind of, it's basically a pulling motion essentially. And a lot of the times in these cases, you'll find that the GP just comes out with 1 or 2 pulls of that, and it kind of just pops out with it. If it doesn't, then you can use a second headstrom file in like a braiding technique. So you can kind of put them both in together, wrap them around each other. But again, very gently, don't wrap them around too many times because you can fracture a file inside.
For this braiding technique, I've seen it been recommended for removing separated files and stuff. But in this instance, if you're using 2 H files, are you now using thinner ones to allow both the files to go in at the same time?
No, I would still probably be using like 35, something like that. Again, because often if the cases we're talking about, they're going to be 1, 2, or 3s. And the access in those cases coronally is quite big, and it can accommodate 2 headstrom files. I don't find that it's that uncommon for me to get 2 headstrom files into these coronally. Obviously, apically, you won't be able to pass those files down, but coronally, coronal third, mid third, you should most of the time be able to get it in there. I'm not sure if that answers your question.
That does. It's just reassuring. And so obviously you're saying 1, 2, 3 for our American colleagues. We're talking about upper centrals, laterals, and canines for our American colleagues. Yeah. And then so the braiding technique, and correct me if I'm wrong, is you put in both the files and then the handles, you literally start like twisting them around and then braiding them from the top. And then on the inside, the files are like intertwining together, which we're hoping will latch onto the GP. Is that what we're hoping?
Correct, yeah. So ideally, you want to look and see if you can get one file on one side of the GP and the other file on the other side of the GP. And then you kind of just wrap them over over each other a couple of times, and then you kind of pull. Again, like if you've pulled a couple of times with a single head strum, it's not coming out. You've tried a couple of times with a braiding technique and it's not coming out. You probably need something a little bit more. And I probably wouldn't push too hard, because obviously the more you put stress on the files, the more likely they are to fracture. So braiding, obviously you're bending the files to a certain degree as well. And if you're pulling motions, bending, it is putting a bit of stress on the files. So if you keep trying to do that again and again and it's not working, I would probably move on to the next thing after that, just to reduce the risk of the file fracturing, essentially.
Okay, so GDP has tried those two things, and what's the next call of action?
Yeah, so then I would be looking at essentially using a file, so a file system to basically remove the GP at that point. So the file system that I would use, often I'd go to something which we call a rake angle. So if you look at the axial section of a file, you cut it down axial sections. Axial section is like a bird's eye view of the file. So when you're looking at a bird's eye view of the file, the way that the teeth of the file, the little points, they kind of curve in a way which they end up biting into the GP rather than brushing it in a way, if that makes sense. So it's called a positive rake angle. So often I'd go for a file with a positive rake angle. The most common one that you see nowadays is reciproc blue. So that's the most sort of common one that has a positive rake angle. And the use of that is that it bites into the GP. So when it reciprocates and bites into the GP, it kind of grabs hold of the GP a little bit, and that can help to pull the GP out as well. So that would be sort of my next step and my next go-to if the headstrong files aren't really working. But again, you need to...
And so when you're using the reciproc blue, because I've never used this one before, are you trying to take it to length and just allow it to sort of take you to length and then pull up?
Yeah, just so I'm on the same page. I'm not saying that reciproc blue is the only file that you can use for this. You can use just things like wave. Yeah, you can use wave 1 and stuff like that. In my hands, I just feel like it's more efficient because of that positive rake angle. Wave 1 will work fine as well, but it's just a little bit less efficient essentially. Because I think wave 1 usually in GDP practice, that is my understanding is that that's the most commonly used file, and it's a really excellent. It's a really excellent file system as well. I actually use it quite a lot as well. But for GP removal,
well maintained the ties with Dentsply there, good man.
Well, I think Reciproc Blue is now owned by Dentsply as well. They've been bought by... They used to be... They're both very good file systems. For GP removal, yeah, my go-to would be Reciproc Blue. Sorry, I forgot what you were asking me now.
I was saying, so are you going to take it to length? Is it safe to take it to length at this stage?
Yeah, so I wouldn't go all the way with the rotary file. I would probably, again, look at the estimated working length, and I would take it up to like the sort of apical third, top of the apical third, or alternatively to within 2-3 millimeters where you think the GP ends. And the reason for that is if you keep trying to go past that, you can end up ledging, and a lot of the times the GP stops at that point because there's a ledge or there's some kind of blockage in there. So if you try to keep pushing the file down there, you can make that worse or fracture a file or make it a problem that would be irretrievable at that point, basically. As in a lot more difficult to negotiate the patency, to negotiate the canal. So I would stop at there where there's still 2 to 3 millimeters of GP left. And then that last apical bit, I would probably be navigating using hand files. So 10, 8, 10 hand files with lots of irrigation. There's just a lot more control that way.
So I can imagine if you get lucky, you go to like towards the apical third with the reciproc blue in this example, and then you pull it out, and then ideally the whole thing, the apical bit comes with it. But sometimes imagine it breaks up, and so it's left like an apical third plug of GP. At that point, you're then using the files again? Yeah,
I would probably be using K-Flex hand files essentially at that point to try and get through. So like 8, 10, those would be what I'd be using to negotiate the apical third. I mean, if the GP is really still, if you get to that point and the GP is feeling quite hard with the hand files. I remember when I started doing Re-RCT cases, you put the hand files in and you're like, okay, it's hitting a stop. Is it blocked? What is it? So the main thing that you're feeling for at that point is to feel for that spongy feeling. And that's how you know you're actually biting into GP. You will hit a stop, but it will be a spongy stop. And that's the GP. If you're hitting like a hard stop, like it feels like it's like kind of pinging off the wall or something like that, then you know there's maybe a ledge or there's something else that's more complicated. But if you're biting into something that's a little bit spongy, you should be okay basically to keep trying. And often I would be using like sort of watch winding motion just to keep the file well centered, or like a small 90 degree pull motions to try and pick at the GP bit by bit.
At what point are you thinking, grab that bottle of eucalyptus oil? Is that so Olbas? Was it Olbas? Maybe it was Olbas oil actually, when I used it. Are you using those little oils, essential oils and stuff?
I use them very occasionally. And the cases that I use them to are kind of limited to if I'm really struggling to get through the apical third of GP. But oftentimes I'd find those are cases which are quite complex to start with. So the GP is already like super well compacted, or it's a really, really old retreatment. So like, for example, the GP has set rock hard, and I tend to find that when the root canal is already already been in place for like 10, 15, 20 years. If it's like relatively fresh, then the GP will normally still be quite soft and easy to pick at. So yeah, I would leave it in there for a few minutes and then pick at a bit more. And the reason I don't go to it that commonly is because it smears, like with the rubber dam example, is it tends to smear the GP over the walls of the root canal. And when we think about the sort of biologically, what we're trying to achieve with the root canal is adequate disinfection. So if you've got a layer of rubber smeared over the dentinal tubules, you've got a lot of bacteria, a lot often hiding inside those dentinal tubules, which then becomes a lot more difficult to access with your irrigation. So although you might have got to the bottom of the canal, you've then just blocked access to a bunch of other bacteria, which could be in the apical ramifications and the dentinal tubules. So yeah, you might be getting through one problem, but then causing yourself another one. It's a little bit controversial. I mean, I think in America, it's a lot more common that they use it. In the UK, I see people, my experience is that my mentors and what I've seen people do is a lot less common in the UK because of that reason.
It makes a lot of sense because if you think about how to remove once that GP has smeared, we know that a file system, you're only really touching 40% of the canal space with the file. Most of it is left untouched, right? And therefore, how are you going to mechanically remove that without then actually over preparing the canal itself, right? Which is obviously the last thing you want to do. So that makes a lot of sense. Now, if for those getting a little bit stuck and they want to use, some sort of solution, can you just name what is it that you use? Is it Olbas or is it eucalyptus? Is it something else that you have access to? And then what's actually the best way to use it? Like, do you dip your file in it and then put it in, or do you actually syringe it in like you would do hypochlorite and leave it there? What's actually the accepted way to use it?
So in terms of what I use, there's a few that you can use. Orange oil, eucalyptus oil. Orange oil is one, eucalyptus oil, and there's Endosolve as well. I'm not sure if the Endosolve original is on the market now. I think they've changed it to Endosolve R. I'm not sure. I'll have to double check that. But there's a few, and these all basically kind of work on different obturation materials. So for example, if you're finding it hard to get down one, you might experiment with the other one and see if you get any further with that. But again, oftentimes if you're having to resort to that...
I didn't know that. That's interesting.
Yeah, I did know when I was sitting my exam exactly which solvents were good for which materials.
Baby brain. Newborn dad.
But yeah, so you might go through a couple of them, but oftentimes if you're getting to that stage, I'd be thinking the re-root treatment is obviously probably a bit more complex at that point anyway. So you might at that point be thinking about a referral if you're really stuck in that apical third and none of the solvents are working.
How to deliver the solvent?
Yeah, how to deliver it. So in terms of delivering it, I would usually use it in a syringe basically. It's the same way that I deliver the hypochlorite, and I just leave it to sit in there for a couple of minutes to do its work. Just kind of, have a little break, just let it sit. And then once it's sat there for a couple of minutes and it's done its work, I would go back in with the hand files basically and just slowly start to pick away at it with the hand files.
Okay, I mean, I'm kicking myself now because I remember years and years ago doing it, and I was like literally dipping my file in it a little bit, dipping in the canal, dipping my file, and like it just makes so much sense. Just leave it to do all the work.
It needs a little bit of a reservoir to kind of work. And if you imagine as well, it's kind of like the hypochlorite. It reacts with the GP. So if you've got a reservoir of it, it's sort of continuously reacting. Whereas if you just put a little bit down there, then you're limiting that sort of reaction process in a way.
Okay, great. And so in the interest of time, I'm going to ask you, my friend, when you're doing these, firstly, single versus two visit. The endodontist that works in our practice that I work at, he is adamant, he swears by two visit. The previous endodontist we had, younger grad, a newer specialist, he liked one visit, okay? And obviously sometimes they'd find a reason to change patient factors, tooth factors, whatever, right? So firstly, I'd like to know, what is your general preference? When you look at your diary and you do like a retrospective, when you look back at your diary, are you tending to do primary root canals in one visit or two? And then does that change because it's a re-RCT, and how you manage that in terms of timing?
So you've kind of touched on quite a controversial topic in endo, to be honest. There's actually quite a big divide in endo among single visit and two visits. So depending on who you ask, they'll probably give you different answers.
That's cool, but I'm literally genuinely interested in what you do, okay? Because you can do it either way. And I just want to just hear from you. What do you do?
Yeah. I mean, I would try where I can to do things in a single visit, because I think that's a lot of the times that's a bit more patient-centered in terms of what the patient wants. So the patient will obviously prefer for you to have things done in one visit rather than two visits. But having said that, if you think about the main sort of biological rationale of root canal treatment, you're trying to disinfect the canal space. If I feel that I cannot adequately achieve that in one visit, then I think the patient would much prefer me to do a second visit rather than increase the risk of it failing. So things that would then push me to doing that second visit, if I think I can't get that adequate disinfection process, is number one, if I run out of time and I can't find all the anatomy that I think is there. So that's one. Then I'd be doing it in two visits. Number two would be if there's a lot of discharge from the canal. So the canal is just weeping continuously. That would be another thing that would make me probably dress the canal as well. And then another thing would be Perioendo lesions as well. That would be one that would dress the canal too. So there is some research to suggest that with perioendo lesions, if you dress the canal, although this kind of comes back to controversy for endo, it might not have an impact necessarily on the periapical healing of the tooth, which is the endodontic outcome. But in terms of the periodontal pocketing, dressing the canal with an interim dressing can improve the periodontal pocketing side of things, as it sort of diffuses through the dentinal tubules into the periodontal ligament space. And then also in terms of teeth with cracks as well, that would be another thing. So if it's got a crack with an isolated pocket, that isolated pocket a lot of the times is where the crack is leaking, bacterial leakage basically through the crack, and that's manifesting as a periodontal pocket. So if you, for example, do the first stage root canal, you clean everything out and then you dress it, oftentimes I'll get the patient back in a few weeks later to see if the periodontal pocket has improved and reduced in depth. If it has, then I'm thinking that crack is probably a crack tooth worth trying to save. If it's not really improving, or it's basically getting worse, then I'm thinking, is this really going to work for the patient? So you can use it as a kind of diagnostic tool in that way as well.
Like a stepwise, careful approach, basically.
Yeah. So I'd be thinking, exactly, yeah. So the other thing is probably really, really significant swellings as well. So if the patient comes in with a massive swelling, that would be another thing that I would sort of be looking at as well.
But you haven't mentioned Re-RCT, so what I'm trying to get to is the fact that it's a Re-RCT, should that push our colleagues, like, so GDPs now, right? So not the kind of specialist what you do, just because the Re-RCT, is there any reason why they should be thinking, oh, it's got to be 2 visits now, or is it still okay to do it in 1 visit?
Yes, so the facts I mentioned, I find that they occur just as much for Re-RCT cases as they do for primary cases, if not more for Re-RCT cases actually, because often the tooth has already been through that restorative life cycle for many, many years at that point. The fact that it's a Re-RCT case in and of itself is not enough for me personally to do it over 2 visits. Maybe if it was a really good quality root canal treatment, that would be an indication, because then I'm thinking as they're sort of more virulent strains of bacteria, but that's not really that evidence-based, to be honest.
Okay, well, I'm going to just take a few questions from the community now, buddy, in the interest of time. Right, let me just head to the community here. There were some questions we had yesterday. Okay, so I posted yesterday saying I'll be talking about this topic, and James got some awesome contributions, and he put up a radiograph of these post crowns, and have a look at this. Look at this central, which like complete destruction, caries, post, root filling, that kind of stuff. And he makes such a real world point here, Ayman. He says, I'd love to hear your thoughts on value for money in retreatments, right? So if you have a molar with an old crown, poor margins, failing, inadequate root treatment, right? The total cost of doing a root canal retreatment, new core, new crown, okay, possibly pre-endo restorability assessment, okay, can be so high that I sometimes question whether XLA and implant will be more predictable option for the patient. For example, the radiograph he posted was his father-in-law's, and then if he's doing the retreatment, etc., and even if he's only paying the lab bills, that's still coming up to a significant amount. So what do you think about this cost versus predictability dilemma, especially in this world of titanium?
Yeah, I think it's actually quite a common
Great question,
scenario.
isn't it?
Yeah, really good question. That's a conversation I have a lot with my patients actually. So the first thing to sort of note is that the survival for root canal treated teeth on average at around the sort of 8 to 10 year mark is still in the like 80-90% range, so it's still quite high, which is probably comparable to implants as well. So that sort of 80-90% range is not too far off what an implant's survival rate might be at that stage. Probably a little bit higher for implants. But the other thing to consider as well is probably their patient's age. So ultimately we're trying to get the patient through their whole life with a functioning set of teeth. So if, for example, you get that 10 years out of the tooth, even though the patient's paid a lot of money for it, granted, you get that 10 years of life out of the tooth, you've then pushed the need for an implant back potentially by 10 years. Whereas if you start off with the implant, obviously you haven't got that life cycle out of the tooth, and to replace a sort of failed implant, if it was to fail at 15 to 20 years, which is a reality of implants, then that becomes a lot more tricky than replacing a tooth. So I'm thinking of it not just, isolated, how long will this tooth survive? It's also how are we going to get this patient through their life with a functioning set of teeth. And yes, a lot of the teeth that we treat root canal treat are very compromised, but it doesn't mean that they won't, work into the future. The other thing to sort of consider is how you are assessing the outcome as well. So a little bit into the sort of nuances of endodontics, but in terms of you want to look at success or survival, which are 2 completely different outcomes. So success is when you're looking at the x-ray, is the periapical lesion actually, reducing in size? Is it getting smaller? That is a lot more of a stricter criteria than survival, which is this tooth still in place in the patient's mouth? So you might have a lesion, is the tooth still in place and functioning okay in the patient's mouth? So how many patients do we see that have massive periapical or big periapical lesions, or not big, but as in like, periapical lesions, but the tooth is asymptomatic and functioning fine in the patient's mouth. So
as a GDP,
the,
I had this
yeah.
conversation a lot, and the patient's like, well, you know what? And we had that informed consent, and that, look, I'm doing just fine. I appreciate his infection. And we had that conversation, and the patient has opted for that. You know, I can live with this. I'm okay with it. And I just say one thing, which is what Dave Winkler taught me. He says, look, that's fine. As long as you understand, it's like a dormant volcano. It can blow up at any point. And I say,
Correct.
Just don't call me at Christmas. I just say that point, and they get it. Like I said, don't call me at Christmas. Okay. And then they get it. It's like, okay, fine.
Yeah. So if you're going by success, yeah, correct. You might find that more of these cases are more likely to fail compared to an implant. But if you're looking at survival, then, you know, it might be that, and I mentioned survival rate at the beginning was 80 to 90%, not success rate. That is because a lot of these patients have these PA lesions which are just sitting there completely asymptomatic, and those cases can last many, many, many years into the future. What's interesting as well is the implant literature. A lot of it, if you compare their outcomes for like with what a tooth outcome would be, it's actually closer to survival. So the implant could have like threads exposed, you know, that kind of thing. But actually what they're looking at in the implant literature is the implant still in the mouth. That's commonly what's looked at.
There could be a lot of bone loss. There could be several prosthetic failures, which are very common.
And when you look at that 90% success survival rate that's quoted for implants is actually quite similar to the tooth survival rate. So yeah, you can have a compromised implant and a compromised tooth, which is surviving many, many years into the future, and that rate of survival is pretty similar for these compromised teeth into the future. So yeah,
I like that ethos of delaying implant as much as possible. So I'm definitely with you in that, my friend. In the interest of time, we're going to wrap up. My wife has to go to some sort of a pediatric dentistry conference, and I'm going to get killed if I don't be there in 2 minutes to help out. But Ayman, as we wrap up now, firstly, thank you so much for spending some time with me today and sharing and helping GDPs just overcome this obstacle, right? And hopefully a lot of those people who had a limiting mindset like I did, you've helped that, but also helped to identify which are the easier cases which we should be doing, and actually lots and lots of good reasons to make sure our endodontist colleagues don't go hungry. Now, Ayman, can you tell us about any either education involved in, or how to follow you, or how to reach out, how to thank you, all this kind of good stuff?
So the main place I'm on is on Instagram. So it's Ayman_endo. That would be it. I've just recently started posting. I'm not like a big account at them or anything like that. That's one. And then, yeah, just any of the practices that I kind of work at. If you have any questions, you can kind of ask for me there or message me on Instagram, basically. So the practice I work at, there's a few. One in Norwich. So they're all listed on my Instagram anyway. If there's any questions, just ask me on Instagram. That's fine.
Well, just, Ayman and I were touching base on Instagram. So thanks for all your replies and stuff. So, having helpful, friendly specialists to just liaise with on a social platform that we're so used to is just amazing. Ayman, if you're interested in a community, come and join us on the app, Protrusive Guidance, and be a resident endo geek on there. But, we're wishing you all the best. Hope Ramadan Kareem and all that stuff, as we're recording in the middle of Ramadan at the moment. So wishing you all the best for that, Ayman. Thanks so much for making this time and making Re-RCTs a lot more tangible for us.
Great. No problem. It was my pleasure. Thank you.
Well, there we have it, guys. Retreatments for GDPs. Thank you, Ayman, once again, our fantastic guest with a lovely deep voice. A nice little feature for those who are listening. Now, listen wherever you are. Please do hit that subscribe button. It astounds me how many of you listen and yet have not subscribed. It does matter to us, so I'd really appreciate if you could. Now, you've done all the hard work. You've listened to some dentistry on the way to work, on the way home, or some of you on your honeymoon or at a birthday party, you're listening to podcasts. You can now get CPD or CE credits. We are a PACE-approved provider of education. The way to do it is head over to www.protrusive.app. Make your account, get a paid subscription. I promise you it's the best value you'll find in dentistry for the quality of CPD that you will get, and answer 4 of the 5 questions correctly. We have an 80% pass mark, and our CPD queen, Marie, every Wednesday will email you your CPD certificate. In an average year, Protruserati are clocking up anything from 40 to 80 hours of CPD a year just from listening on their commutes. And as you know, we've also had core CPD, which in the UK means mandatory training that you have to do, which is usually very boring and very stressful when it comes to December, but now you can do a big fat tick and hopefully would have enjoyed the process too. You have many colleagues from around the world, US, Australia, you name it. You are also claiming your CPD, and it's just great to see those numbers grow month by month. So be part of it if you want to formalize your learning into a certificate. And of course, don't forget to download the premium notes available to all our paid subscribers. Our best plan is on protrusive.co.uk/ultimate. And yes, we have the app on Android, iOS, but I always say to everyone, make the account first on protrusive.app, not on iOS, Android. So the best way to do it is make it on your laptop and then use those login credentials on the native app. Thank you once again, guys. I'll catch you same time, same place next week. Bye for now.